You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 3rd, 2025. This week, two great stories of translational science leading to beneficial drugs in terrible diseases of the heart, and the Sisyphean task of predicting the need for permanent pacing after TAVI. The lessons transcend just a simple EP question of pacing. Okay, the first topic today is a new drug that I don't think I've talked about on this podcast called a Sotatercept. Now, it's for pulmonary artery hypertension, and I don't take care of patients with PAH, and perhaps you don't either. But I want to spend a few moments talking about this amazing story of translational science and a breakthrough treatment for a disease that is progressive and terrible, and that is primary pulmonary artery hypertension. Here's a brief background statement on PAH that I took from an editorial from Dr. Bradley Moran in New England Journal of Medicine this May. Pulmonary artery hypertension is an uncommon disorder. It's characterized by pathologic remodeling of distal pulmonary arterioles, and these changes increase PVR, pulmonary vascular resistance, which leads to a clinical syndrome that is manifested by decreased exercise capacity, impaired functional status, and hemodynamic instability. Most patients with PAH will have progression that can be rapid and relentless. Therefore, clinical management emphasizes early diagnosis, aggressive upfront pharmacotherapy, and prompt intervention for patients with an unfavorable course. Now, how uncommon is it? I would say rare. One estimate I found online just searching was that PAH affects only about 500 to 1,000 new people per year in the U.S. That's not very many. And one more nugget of background, Sotatercept is a first-in-class activin signaling inhibitor that targets ligands in the transforming growth factor beta superfamily. And these are implicated in PV remodeling and cellular proliferation. And this is key because the disease, PAH, is at its core an imbalance between proliferative and anti-proliferative signaling. Indeed, we now understand it's fundamentally a vascular remodeling disease caused by cellular proliferation gone wrong. To wit, old thinking had PAH as a vasoconstriction problem, blood vessels narrowing. New understanding holds PAH as fundamentally a vascular remodeling disease. In healthy pulmonary arteries, there's a balance between proliferative signals that promote cell growth and anti-proliferative signals that restrain cell growth. In PAH, this balance tips towards excessive proliferation of pulmonary artery smooth muscle cells, endothelial cells, and fibroblasts, and loss of anti-proliferative signaling, which results in thickened vessel walls, luminal narrowing, and increased resistance. Sotatercept is thought to work because it acts as an activin trap to reduce proliferative signaling. In turn, this restores more of the normal proliferative anti-proliferative balance, and it has been shown to actually reverse some of the vascular remodeling, not just dilating vessels. Now, I cover the drug this week because New England Journal has just published yet another stunningly positive RCT. The RCT was called Hyperion. Now, I've often been critical of industry cutting corners, spinning clinical research. My review of the Sotatercept evidence this week leads me to a place of optimism regarding science done correctly, even though it's industry-driven. The Sotatercept trials are refreshingly simple. One group gets the drug, the other placebo. They then measure strong clinical endpoints. Hyperion randomized patients with moderate to severe PAH and was new in onset. These patients were already on double or triple therapy. The primary endpoint was clinical worsening, which was a composite of death, unplanned hospitalization for worsening of PAH, atrial septostomy, lung transplantation, or deterioration in performance and exercise testing due to PAH. 320 patients were included. There was a 2-to-1 randomization, a duration of follow-up just over a year, and the trial was stopped early because of benefit. At least one primary endpoint event occurred in 10.6% of the patients in the Sotatercept group versus 37% in the placebo group. That's a hazard ratio of 0.24, highly statistically significant. We're not used to seeing hazard ratios of 0.24. Deterioration in performance and exercise testing due to PAH occurred in 5 versus 29%. Unplanned hospitalization for PAH, things that occurred 1.9 versus 8.8, all-cause death was similar. Again, the trial was only 12 months. The primary endpoint curve separated within 10 weeks and continued to separate. Overall adverse events were Sotatercept had more epistaxis, 31.9 versus 6.9% of patients, and more telangiectasias, 26.2 versus 11.2. Adverse events leading to discontinuation of the trial regimen were reported in 3% of patients in the Sotatercept group and in no patients in the placebo group. Serious bleeding events in 3.8 versus 1.9 Sotatercept and placebo, respectively. I'm not sure why epistaxis and telangiectasias are the more common adverse events, but they clearly are. So my comments, I, like you, are probably not an expert in PAH. I'm not an expert. But gosh, these are remarkable results with immediate curve separation in a seemingly internally valid RCT in patients already on typical background therapy. At 12 months, my friends, the 22% absolute risk reduction is an NNT of just 5 patients. And these findings are not an outlier. Earlier this year at ACC, we heard results of the placebo-controlled Zenith trial of Sotatercept in patients with severe PAH that also reported similar findings. In Zenith, the primary efficacy endpoint of death, lung transplant, or hospitalization for PAH was 17 versus 55%. That's a hazard ratio of 0.24. That's an NNT of about 3 patients. 3. Now, I did some Googling and looked into the large language models and found that these are highly costly drugs. Claude quoted an Institute for Clinical and Economic Review, or ICER review, that calculated Sotatercept should be priced between $18,000 and $35,000 per year. ICER uses cost-efficacy tools, but this is dramatically lower than the actual cost. The actual cost, I learned, was about $240,000. Now, look, doctors can't control cost. You and I, we need to consider cost, but from a critical appraisal and evidence standpoint, I see this as a cool story where basic science research and discovery of mechanisms then led to a successful clinical therapeutic. And like I said before, I'm often negative on some industry tactics, but here's a case where profit motive and innovation lined up and helped patients with a serious disease. Yes, we certainly need solutions for drug coverage, but that's not a medical issue. That's a policy issue. I wish the translational science situation for PAH were the same for AFib. Instead, in AFib, we get catheters that are faster and allow us to do more PVI without any understanding fractionally close to what PAH experts now know about their disease. All right, next topic is a drug called Acoramidis and ATTR cardiomyopathy. Speaking of drug innovation, patients diagnosed with transthyretin amyloid cardiomyopathy, ATTR cardiomyopathy, also have new drug options, though perhaps not as remarkable as Sotatercept and PAH. At the heart failure meeting in Minneapolis this week, investigators from the placebo-controlled Attribute trial of Acoramidis reported a post-hoc study looking at total recurrent events. The original Attribute trial was published in New England Journal of Medicine in January of 24th, and it had a win ratio type analysis of the composite primary endpoint of death, CV hospitalization, change in BNP, and change in 6-minute walk test. In the 623 patient main trial, Acoramidis led to many more wins than placebo. The win ratio was a highly significant 1.8 with confidence intervals 1.4 to 2.2. Before I go to the post-hoc analysis that was published in JACC, let me say a word on ATTR cardiomyopathy and the drug Acoramidis. So ATTR cardiomyopathy is a progressive fatal disease. It's characterized by destabilization of the tetrameric transthyretin, which misfolds, then causes the aggregation of amyloid fibrils in the heart. The echocardiograms of these patients are stunning in that the myocardium gets super thick, super bright, and you can almost see the diastolic dysfunction without any measurements. The prognosis is terrible, and patients suffer with frequent episodes of congestive heart failure. Acoramidis works by binding to TTR and stabilizing the protein structure, preventing it from breaking apart and forming the harmful amyloid deposits that damage heart tissue. And, similar to Sotatercept, there was an interesting twist in the discovery of Acoramidis. And here's what happened, or at least how I understand it. A rare mutation called T119M, which is not important in the name, but it's a gene coding TTR, results in a variant with a better stabilization of the tetramer than in wild-type TTR. Now, this happens because of unique hydrogen bonding that I don't understand. But these patients had increased TTR levels and better clinical outcomes. The drug, Acoramidis, is a novel TTR stabilizer designed to mimic the action of the T119 variant. It achieves near complete stabilization in wild-type TTR and across all other variants. Now, as compares with other well-characterized TTR stabilizers, such as tafamidis, Acoramidis has shown improved potency, binding affinity, binding site occupancy, binding thermodynamics, and TTR stabilization when it's assayed by a number of quantitative techniques. In other words, there's a strong mechanistic reason for the positive results in the ATTRibute trial. Now to the newest study, which was presented at the heart failure meeting and published in JACC. This was a cumulative analysis paper, namely patients could have multiple CV hospitalizations, and the original trial looks at the first event. I kind of like recurrent analysis papers because from a patient perspective, it gets to the total burden of their problem, and I think maybe a more realistic estimate of the effect size. The main findings was that Acoramidis significantly reduced the cumulative risk of CV events through month 30 versus placebo. The hazard ratio was 0.51. Again, nearly 50% reduction, highly significant p-value. A notable proportion of CV outcome events, 19% of CV mortality or recurrent CV hospitalizations, 22% occurred within the first 6 months. The authors noted that the benefits in CV hospitalization started to occur in 1 month. By 2.5 years, the estimated benefit, this is the absolute benefit, was that 53 recurring events were prevented per 100 treated patients. That's a lot. The authors emphasize that the early and large effect of the drug has clinical implications, and unlike tafamidis, which had those famous Kaplan-Meier curves which stayed the same for about 2 years and separated after 2 years, Acoramidis seems to act quickly. Notable, too, was that the ATTRibute study, tafamidis was allowed after it was approved, and about 18% of patients received it. Interestingly, and I have no explanation for this, more patients in the placebo arm were taking tafamidis, 23% versus 15%. I'm not sure why this was, if randomization was robust or blinding was achieved, or maybe it was just chance. But nevertheless, since more patients in the placebo arm were on tafamidis, this may have blunted the effect of the drug. Now, a couple of sober observations, though. In the tafamidis trial, remember, the primary endpoint was all-cause death. In ATTRibute, it was a win ratio of a lot of different things. And in this post-hoc analysis, it was recurrent CV events, so it's hard for me to tell if the results are that much better for Acoramidis than tafamidis. For instance, the death wins versus losses in ATTRibute with Acoramidis was 15% versus 13%. That's better for Acoramidis than placebo, but it's not much different. I wonder what would happen if the same win ratio and outcomes was used in the tafamidis trial. The second observation is, as it so often is in heart failure, the subgroup analysis of the ATTRibute trial showed that all of the Acoramidis benefit was in patients with class 1 and 2 heart failure. The 16% of patients in the trial who had class 3 heart failure seemed to get no benefit, so that patients discovered late in their disease with bad heart failure may not benefit. The final comment is on the cost and order of treatment of these drugs. I don't know that it is clear which order to start these medicines in, or whether patients need to be on both types of drugs, or What is the role of vutrisiran, another drug for ATTR, which works by inhibiting production of hepatic transthyretin? I guess the job of people like me and you is to be aware of the diagnosis, look for it, diagnose it early, then send these patients to our heart failure colleagues. Now, I have no idea how normal people could afford such expensive medications. Clearly, we need policy work on drug pricing, but again, that is not the role of medical people like you or I. All right, third topic today is pacing after TAVI. Another tough problem in EP is the decision to place a pacemaker after a patient has a TAVI. Why? Because sometimes patients who have AV block recover never to use their pacer again. These patients are likely harmed by having implanted hardware. And sometimes patients who have conducting system injury after TAVI who don't get a pacer because things are hanging in there go home and collapse with heart block on day 3 after TAVI. Now, the ideal situation from an EP standpoint would be to keep these vulnerable patients in the hospital for a week, but that's not really a realistic option in 2025. Though I remind young listeners that in the 1990s, when I started, patients would be admitted for a month or more taking serial antiarrhythmic drug testing for VT. The journal Heart Rhythm has published 2 big studies of post-TAVI pacing issues. JACC-EP is another sub-study of one of these. So, first, a Quebec-led group of multiple centers reported in JACC-EP a sub-study of a larger study of pacing algorithms after TAVI. The larger study, which is published in Heart Rhythm, was called PROMOTE, and it was a multi-center prospective study of about 2,000 patients who, without prior pacer implant, who had TAVI. This study grouped patients into 3 groups: those with no conduction disturbances, those with right bundle branch conduction disturbances, and those with any conduction disturbances after TAVI, mostly left bundle branch block. The protocol involves mandated temporary pacing depending on the group, but the decision to do permanent pacing was ultimately left up to clinicians. In the end, the PROMOTE study found that using this complicated algorithm, the pacing rate was about 15%, and there were no differences in outcomes in any of the pacing groups. The authors wrote that having a specific protocol did not reduce the pacing rate over what is known in historical controls. So PROMOTE was one study. A second study was from the Basel group of EB docs, and it aimed to evaluate the ESC criteria for risk stratification of right bundle branch block undergoing TAVI. They retrospectively analyzed 1,400 patients with pre-existing right bundle branch block who had TAVI between 2011 and 2023. The ESC criteria for pacing that were validated included a change in PR interval greater than 20 milliseconds, QRS axis change, and or transient high degree AV block less than 24 hours after TAVI. About 8% of patients who had TAVI had a pre-existing right bundle branch block. Of these 107 patients, 34% had persistent high degree AV block lasting longer than a day. And for those 1/3 of patients, they had a pacemaker, no issues. They had to have a pacemaker, complete AV block. Of the remaining 71 patients, 16 patients, or 23%, had delayed high degree AV block during 30 days of follow-up. The ESC criteria identified, here's the key finding, the ESC criteria identified 81% of these patients, 13 of 16, who had delayed AV block during the 30-day follow-up, while missing 3 patients, which actually turns out to be 19%. This resulted in a sensitivity of 81% and a negative predictive value of 92%. Now, meeting the ESC criteria bore a 6-fold increase in the odds for development of high degree AV block during the 30-day follow-up. That odds ratio is 6.5, but the confidence intervals go from 1.8 to 30. The Swiss team concluded, quote, "In this large cohort of patients who have pre-existing right bundle, undergoing TAVI, the ESC criteria, PR prolongation, QRS axis change, and transient high degree AV block correctly identified 4 of 5 patients in whom high degree AV block developed during the 30-day follow-up." I'll discuss this along with the other studies together. So let's move to the PROMOTE sub-study, which was in JACC-EP. This dealt with outcomes from prophylactic permanent pacemaker after TAVI. I know what you're thinking. The modifier prophylactic and permanent pacer don't go together, right? We use pacers to treat symptoms, period, always. But TAVI is different, isn't it? So let's see what happens in this report. In a larger promote study, prophylactic permanent pacemaker implant was considered in cases of a wide QRS with active changes daily, so a daily PR or QRS interval increase, or new onset persistent changes of a PR interval greater than 240 milliseconds or greater than a QRS of 150 milliseconds. And just an aside here, these are hard to look at after a TAVI. These are remarkably abnormal ECG findings. And remember, the TAVI valve pushes right on the left side of the conduction system. And this is the cause of conduction disturbances. In fact, when we can't get AV block when we're doing right-sided ablation for AV node ablation, if you go to the left, retrograde aortic valve, it's amazingly easy to record a His bundle and ablate the junction. It's very superficial on the left side. I'm surprised that AV block occurs so little, actually, with TAVI. So getting back to the sub-study, a total of 329 patients with permanent pacemaker post-TAVI were included in the main promote study, but 80 of these, so 1 in 4, 24%, had a prophylactic indication. The main indication for prophylactic pacemakers was new onset persistent left bundle branch block with a QRS wider than 150 milliseconds and or a PR interval greater than 240 milliseconds. And their outcomes at 1 month were similar in prophylactic and non-prophylactic pacemaker implants. But the median rate, here's the key finding, the median rate of ventricular pacing percentage was significantly lower in the prophylactic pacemaker group, 2% versus 73%, with a higher rate of patients with a ventricular pacing percentage less than 1%. That's 42% versus 14%. Let me just say that again. Nearly half the patients who had prophylactic pacemaker implantation had a pacing percentage less than 1%. And prophylactic pacemaker implant after a positive EP study where the HV interval was greater than 70 did not seem to impact the pacing burden at follow-up. The authors concluded that about a fourth of patients who get a permanent pacemaker had it done preventively, but about half the time in these cases, the patients who had pacers for preventive reasons did not use them, the pacing percentage less than 1%. And quote, these findings would question the systematic use of prophylactic pacemaker implant after TAVI. Okay, my friend, an all-around nice person, Pasquale Santangeli, wrote the editorial for the 2 Heart Rhythm Journal papers, and he included the phrase in this title, "One must imagine Sisyphus happy." Indeed, risk stratification post-TAVI remains a Sisyphean task, one which I don't think even the most advanced AI will ever conquer. The problem with both studies of using algorithms, the ESC criteria or the promote algorithm, is that they are decently sensitive and specific, but they're not 100%. And that's a problem because being wrong about not using a pacer post-TAVI is similar to being wrong about not putting in an ICD where a patient has sudden death, or missing an MI in the ER. The consequences of this are dire. But, the problem of being perfect can lead to much harm, right? If you use tighter criteria for pacing implants, say preventive pacing, you end up putting hardware in people for no reason. That's not good either. It's the same with trying to be perfect in the ED and never missing an MI. If you do that, you'll harm a certain percentage of people with overzealous diagnostic procedures, like complications from a diagnostic angiogram. I mean, most cardiologists can tell a story of a dissected coronary from an angiogram that had a dubious indication, because we're trying to get to perfection. Medicine writ large would be improved if we were honest about exactly what the incidence of missed MI is acceptable. It's not zero. I think post-TAVI pacer decisions are similar to that. The goal, I think, is not perfectly preventing every late collapse from AV block, but deciding on what incidence of post-TAVI collapse and late AV block we can accept and how best to minimize it. Look, I think there's only 2 ways to prevent every case of post-TAVI delayed AV block and collapse. One is to not do TAVI, which is obviously not a good idea. And the second way is to implant a ton of pacemakers, many, many more pacemakers than is needed. And that's going to cause a lot of harm from unnecessary pacing, and that's not a good option either. Now, we've done things in our hospital like active monitoring. I'm sure you have, where the patient goes home with a monitor that's being actively monitored. This isn't perfect, but it's a potential solution. I think in the end, my friend Pasquale is correct. Doctors have to make tough decisions. The preventive pacer indeed can be done, but as the promote team has shown, a huge number of people will have unnecessary hardware. So I think we have to accept imperfection and uncertainty and do our best to make the best decisions possible. All right. The next topic it was going to be how I might have been wrong about a study this past week, and it had to do with GLP use in patients with HFrEF, which is an interesting topic with not too much data. I've already gone on for the usual 25 minutes or so next week I will start with an intriguing observational study which suggested potential harm from using these remarkable GLP drugs in patients with HFrEF, or heart failure with reduced ejection fraction. And I will tell you how I might have been wrong with my initial impressions. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review. I talked about things that I'm not expert in today, PAH and ATTR cardiomyopathy. So if you have something to add, or I didn't say something right, please correct me and I'll make a listener feedback next week. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.